Welcome to the Functional Code, your go-to source for decoding optimal health. Join Dr. Addy and Dr. Jace as they break down the science behind pain, performance, longevity, and more, making complex concepts easy for you to understand and apply in your life. Your journey to a healthier you begins with understanding the Functional Code.
Disclaimer: the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Welcome back, everybody. We have the Functional Code coming at you, episode 14. This is going to be a great one. I know I'm excited, Doc. This one we've been talking about now for a while. I know that myself, I've been trying to find a good time to where we can fit a lot of this information in, but today we're going to be talking about regenerative medicine. This is something I think many people have a good understanding about, but there's still a lot to know when it comes to the topics included. So today, I am Dr. Addy.
And I'm Dr. Jace. And yes, this is going to be an episode to where, if you guys have heard the saying, blind leading the blind, it's definitely not going to be like that at all. Dr. Addy is going to do an awesome job today going over some of the regenerative medicine. I'm going to learn some things. I'm going to almost take a little step back and learn with you guys, and then ask questions on when he's going through some of this that I would have questions too, so we can all learn together through this whole process. So when we're going through these regenerative therapies, this is a lot of the newer stuff that's come about in the last 20, 30 years, give or take. And with these new therapies coming through, it's allowing us to treat and heal people, to improve the overall function, longevity for people of all ages, races, which thus when they say that wait for the medical system to improve, this is where a lot of this is coming from. So as we dive into this, we're going to be going over PRP or platelet rich plasma. We're going to go over stem cells. We're going to also dive into exosomes, and these might sound like fancy words, but we're going to explain each and every one. What are the things that will work better for you? What are the things that you should look for? What are the things that you should ask providers? What are the things that you should pay attention to when giving or recommending these therapies? We're going to dive into a lot of these small tactical things, but making this information widespread so everyone can understand it and where we're at with medicine thus far, especially from the conservative route. So, Doc, let's dive straight into platelet-rich plasma. I guess, what is PRP? What are the benefits? And explain to us, why would patients want to have it done?
Yeah, absolutely. So, to get started, a lot of us have heard about PRP, but if you haven't, what it is PRP just means plasma which contains a high amount of platelets, which is in your blood. And in order to create PRP, that's exactly how it's done. We take the blood out of the body, we put it into a tube, centrifuge it, spin it down. Now what that does is it separates the red blood cells and other cells away from the plasma portion of the body. The plasma is yellow in color, so when you spin it down, you'll see the red portion is towards the bottom of the tube. You have a buffy coat layer, and then above that is yellow, and that's the plasma. And inside the plasma contains many platelets. And platelets are what heal the body. They're very healing in theory. There's also in that plasma is going to be many amounts of growth factors, other types of things that heal. So what we do is we draw that away from the tube, and then now we, in the syringe, can put that really anywhere we want. And so and what's very interesting, and people do not know this, do you know what else is in that yellow bit? Exosomes. Because we have our own stem cells and exosomes in our body. And so we do have other regenerative properties in that plasma that people just don't know about. So we're trying to still understand what is truly doing all of the healing when we are injecting that plasma properties into the body. So there's platelets in there, growth factors, there's even exosomes, our own. There's a lot of things in there. And that's where we're trying to still understand where we can apply the plasma, whether that's locally to a joint, even into the face, the skin, all of these things that are being done. I've even done it intravenously. You can inject the plasma in a vein and use it systemically. And I have seen some pretty amazing things being done with PRP intravenously. But again, we still have so much to learn about when we would do that versus when we wouldn't. And so really the main benefits that PRP can bring about is really just a way to increase healing to an area. And it's great because it's your own properties, so it's already selected to you. So there is no chance of rejection. There's really very little chance of any adverse side effects. And you can even actually manipulate the plasma in a way that is even what's called platelet-rich fibrin. And that's where you take the plasma and you can actually cool it down and make it more gel-like. And then now it's similar to like hyaluronic acid. So you can now take, and what a lot of clinics are doing are they're actually taking it and manipulating in a way that makes it more efficacious for maybe a joint. So making it more jelly-like. So they're really just taking that plasma and they're cooling it in an ice bath for 5 minutes. Then they're taking it, now it's more gel-like, putting it into the joint. They're doing so many different things with this. And I think moving forward, you're gonna find that PRP will start to replace steroids, other types of modern medicine for pain management, anti-inflammation, just because it can be used in so many ways and it is so efficient.
A question that comes to my mind is like when we're taking blood out, we're separating the plasma and then reintroducing that back into the body. Why do we even do that when we have the properties already in the bloodstream? Why do we go that route instead of having the body kind of heal itself?
Good point. And really what you'll find is, of course, someone who is either a poor healer or has an injury to the extent of the healing just isn't all properly done correctly. We've seen so many times where a patient finds themselves in this loop of chronicity and they just can't get past this healing stage. Well, what we know is when you take a look at the stages of healing, the first 3 or 4 stages are done by the platelets. And so what we can do is we can reintroduce a very high concentration of platelets to that area that just by regular blood flow wouldn't create that amount of platelets. You'd only see so many per milliliter in your blood arrive to that area. And if it's such a tremendous injury where just by blood flow alone it doesn't get enough to actually correctly heal that area, this is where you can introduce an even higher amount than it already would have to help with the healing naturally.
That makes way more sense.
Yep.
Okay, cool. Awesome.
Yeah, and a lot of patients, again, there's this theory that a lot of clinics and providers have, researchers have, which is you are what the plasma is going to consist of. So if you are older, if you smoke, if you take certain medications, if you've had vaccinations, if all of these things now are in you and can create a certain plasma outcome versus a younger, healthier, someone who takes care of themselves, plasma. And each property is going to be different. So then the question of when would you use PRP versus when you wouldn't is still now an emerging theory, because someone who's a smoker or maybe is on blood thinners, maybe they have low platelets as far as like a disease, that's where we maybe say this is not a therapy that we would maybe choose to do, and instead we would choose to do something else because it just won't be as efficient.
So when you said that each person has their like own makeup based on what resources come in their body, would it be more advantageous to have blood drawn when a person's younger or early on in age, and then do they store it in like a bank of some sort and then utilize that later in life? Or
with PRP, great question. With PRP, it's not being done like that yet.
Okay.
What we're finding is if they are younger, we do have better outcomes, and especially if they've taken care of themselves if they're younger. There are a lot of providers who won't typically do PRP on someone who's maybe above the age of 60. Not to say that they haven't, it's just they might choose a different therapy because what we find is it just isn't as effective. Now, a good way to understand why is every year we age, we lose more and more healing properties, growth factors, stem cells in our body. And so if you were to take someone who is 60 versus 30, you could find a tremendous amount of more growth factors and stem cells in the younger person. So that is just something that I think a lot of providers need to understand and realize when first recommending this therapy. Just because if you were to choose to do PRP, you would want to make sure that the therapeutic dose is being reached. And what I mean by that is, I don't like this, but I'll use this because I think it'll be easy to understand. But let's say you have a really bad injury and you take one ibuprofen and it reduces your pain by maybe 20%. You would probably get better outcomes by taking 2 or 3 because of the extent of the injury. It's going to be the same with these therapies. You need to have a high enough dose of platelets in order to reach what we would call a therapeutic dose so that we actually get the results that we want. And too many times, providers still aren't measuring what they're doing. And that's not going to be helpful when we need to know and understand what that therapeutic dose is.
Man, that makes a lot of sense. And even when you brought about the healing properties, and older in age, there's not as many healing properties. I look at this the same as like there's only so many white blood cells in your body to fight infection, to repair tissue. So from a practitioner standpoint, I'm thinking, okay, if someone's going through an illness, injury, I don't necessarily want to break down their body, do a whole bunch of muscle work. I'm sure there's certain similarities, especially with like lymphocytes, that can also be incorporated back in from the plasma itself. So does that play into PRP at all in terms of the properties of the specific PRP?
Absolutely. So you brought up white blood cells, and this is starting to become more of an emerging theory of research, and that's using what's called leukocyte-rich or leukocyte-poor platelet-rich plasma. And leukocyte is just another term for your white blood cells. And so when we have leukocyte-rich or leukocyte-poor, if we have a higher leukocyte count, we're going to have more of an inflammatory response because that's what they do. They fight, and they promote pro-inflammatory components. So when someone, let's say, receives a leukocyte high, that's someone who we relatively want to create a high amount of inflammation, like a joint or even something muscular or something where it's really, really chronic, and you want to make sure that there's a high enough of an inflammatory response to create a healing. But what that does is it can further exacerbate swelling, it can further exacerbate soreness, pain, maybe puffiness, redness. It's a pro-inflammatory treatment. So that's just something that is going to come with this form of treatment. But where we wouldn't want that is, let's say we were doing healing in the face. This is where you can actually try to reduce the amount of leukocytes, because obviously if we're going to be injecting it in a very thin skin, especially facial aesthetics, we don't want to have those properties. So you can actually try to remove that, and you'll find leukocyte poor is going to be much more effective when we're doing more things in the skin.
That's crazy. I had no idea that they can either add more leukocytes into certain areas for certain properties, and an area, especially joints, compared to the face. Like, that's incredible.
And you can also do platelets too. So you can have platelet rich or platelet poor plasma. And what you're finding is platelet poor plasma is a great way to actually do controls in a study. So instead of having saline, you can try to actually get something that's more closer to PRP. And so you can use almost a zero to little to no plasma that have platelets in them versus something that has an immense amount of platelets. And then you can compare the two to show why PRP versus having no platelets in the plasma is more advantageous.
Wow.
And you'll even find that platelet poor plasma is still effective compared to saline. And so now they're starting to understand when they would want to use PPP, platelet poor plasma, versus PRP, which is platelet rich plasma.
No idea.
And so all of these things now are starting to emerge as far as what we first thought was you take, I mean, this is the beginning, was you take your blood, you spin it down, you take the yellow stuff out and you put it somewhere, which in theory is going to be helpful for a lot of things, but when you can start to break down the actual science of what you're taking and why, you're going to get much, much better outcomes.
Wow, they don't teach us this in school,
No.
which is weird. And now that knowing that there's different properties of PPP versus PRP versus adding in more leukocytes or less, we can be more precise with like everything. And even when you're saying control studies, saline versus PRP, and going back and forth between PRP and PPP. But is there any FDA approval? I guess, where are we at in terms of regulating and putting this into the hands of America?
Yep.
Where are we at in that stage?
Yeah. So what's very difficult about PRP is it'll never be able to be FDA approved because it is a human-born product. So there's no way to regulate a consistent product outcome because every human is going to be different. So what we're going to have to figure out is a guideline on how to use this, and we're going to have to figure out a way to have some type of regulatory body to give you advice on how to create the best extraction isolation protocols while you're doing this in clinic so that you can obviously have the best outcomes, safety, efficiency, those kinds of things. And we're getting to that point, but we still are very far from having uniformity and consistency across use. And this is kind of when I was talking about making sure you have the therapeutic dose, making sure that you're doing it consistently for the best outcomes, because a lot of clinics are coming up short when it comes to extraction, isolation, measuring, making sure you have the right dose.
That's fascinating. So there must be a time range in terms of when it's beneficial, obviously depending on what condition that person would have. But let's say there is chronic injury to the area, overuse. Let's say there's degeneration. Someone's thinking of, okay, either are we looking to go surgical route? Are we looking to go steroid injections? Or are we looking PRP, I guess? What is the comparison between PRP and other modalities, and where does PRP rank between all those?
For sure. When we started using PRP, we definitely created a large body of research in the orthopedic realm. And we used it mostly right away for joint pains, muscle pains, those kinds of things. But we actually are even getting into dental and even autoimmunity, other types of things as well. But when PRP would come into play, it would definitely pair right now similar to like a cortisone injection. And a lot of the research being done, you'll find cortisone is a comparative property or modality being used as a comparison. So what you'll find in the body of research is PRP consistently across, I would say, most research being done is either just as effective as cortisone for joint injections, muscle injections, rotator cuff, shoulder, knee, hip, you name it. I mean, it is relatively close to outcomes as far as 3 to 6 months for cortisone. But in my opinion, from what I'm reading, it has even a little bit better outcomes in the 12 to 18 month realm. And that's just because when you can create this cascade of healing, which cortisone unfortunately does not do, because cortisone actually has more destructive properties to it. And there's even research showing that cortisone can delay or inhibit healing.
Yeah, and I've seen studies myself too. It's either 50-50 shot for cortisone injections, and that's why we don't push it as much as we do. But now knowing some of this, like, it opens my mind.
Athlete studies, I'm sure you've read how cortisone or ibuprofen NSAIDs are not recommended early on for athletes because it does delay healing, and you want to get them from return to play. That is something that they recommend do not do. And that's where PRP, in my opinion, like I said, is going to replace a lot of this, because not only do you get the same outcomes in the short term, you get such great outcomes in the long term. And what you'll find is, and this is still where we need better research, but the best that we have right now is once a week for 3 weeks can get you 3 to 12 months of benefit. comparative to cortisone, which at best studies have given the 120 days a max. I mean, yes, patients, we have few and far between that come in and say, I got a cortisone shot last year, I'm good to go. But I don't find that at all with most patients. It's, I got it and I'm a week later in pain, or maybe a month or two later in pain. It really doesn't last.
And there's a reason why they put a limit on how many you can have done in a matter of like a year or two. But is there any limit on the amount that you can have done PRP, especially if it has equal, if not better results short term and way better long term? How does that look like in terms of the amount of times you can have it done?
Yeah.
Is there restrictions? Obviously, I don't know if there's research, but
yeah, we are still trying to figure out if there is maybe a maximum dosage needed.
Sure.
And I don't think off the top of my head we've had a good amount of research on maximum use. But what I have done as far as experience-wise, and I definitely want to touch on, you had talked about there's a limit on cortisone. And I think people need to realize why. Because too much cortisone can actually cause cataracts, it can cause osteoporosis. You can even have, if you're diabetic, drastic changes in your blood sugar management. There are a lot of unfortunate side effects with high amounts of cortisone.
even just breakdown of soft tissue around
For
the
sure.
area. Yeah.
The best way I've had it was just explained to me by a neurologist, actually. He told me the cortisone is a joint blow up. He's like, it goes in and it just blows the entire thing up. You have no pain. But as far as healing goes, he's like, you've kind of inhibited in it. It's really stuck in place. Dr. Morgan, chiropractor president for Parker,
Oh, sure.
he's a very well-known expert on management of back issues. He even worked in surgical centers. He very well high up in that department. He has done before and after experiments, research on cortisone injections for herniated discs. And he found that cortisone was freezing discs in place, and it was inhibiting your ability to resorb a herniated disc. So he'd do a MRI before they did the cortisone. 6 months later, that disc didn't resorb. And if you go back to our low back podcast, you would find discs should resorb in about 5 to 6 months.
Yes.
Cortisone was actually pausing that, and you were inhibiting the healing. So that's another thing is yes, you took the pain away, but now you inhibited your ability to actually get rid of the problem. And I don't think a lot of people understand just why cortisone, is my opinion, isn't the place to go with musculoskeletal issues.
Okay, so playing devil's advocate to a certain extent, let's say a patient would have a cortisone steroid injection in the back. Let's say it's been a few months, they come to us and we want to do PRP in that exact area. But if you had the PRP and there's already freezing and blow up of that area from the steroid injection, would there be increased healing benefits that the PRP could possibly reverse that whole process?
Yes, in theory, yes.
Okay.
I don't know if I, off the top of my head, know of any studies done after corticosteroid injection, but there are intradiscal studies of PRP. And what they find is it's safe, and it can actually help improve that macrophatic cycle to actually try to eat away that disc and improve resorption. And so anytime you can improve that process, which needs to happen, and a macrophage is basically just a cell that comes in to eat away foreign, let's say foreign debris that the body doesn't want or need. And it's used in many other processes, but in this case, the foreign debris is the disc that has been herniated and is now pushing against your nerve or other parts of the spinal cord. And the PRP can actually, again, because we know in theory, step 1 through 4 out of 6, step 1 through 4 is all done by platelets. And we'll get to what 4 and 6 is and why platelets should be important early on, because what's step 4 through 6? Stem cells. That's what kicks in. So, but back to what you were saying, yes, intradiscal injections are commonly used and safe, and making sure that you can actually do that in that area. You can even do it aside of it, called a parafacet, where you're putting the platelet plasma next to the joint, not actually in it, if you don't want to be that invasive. And you'll still find it can create this healing effect next to the joint and still get good outcomes.
Oh my goodness, okay.
Yes.
Okay, so let's think about certain areas. So I know you brought up back discs, 'cause that study was just powerful in my mind when I'm healing and treating people. So if you have back disc issues, let's definitely open up your minds to PRP because it makes a lot more sense and way better for your body long term. But okay, what about rotator cuffs? What about other areas of the body? Knees, ankles, feet, toes, maybe just even muscle tissue, strain sprains. With all those in comparison to like some of the steroid injections that would typically be done on the medical side.
So basically what I brought up here today to talk about as far as pain conditions and what PRP can help with, I kind of picked the low-hanging fruit of what PRP has been studied on in a lot of the maybe higher bodies of research, but there are definitely more things it's being used for, but just for the sake of commonalities, this is kind of what I brought today. So what we know is it can absolutely be helpful. Now, I don't want to say it is, but it can be, because there's always going to be discrepancies with studies, and we still have plenty of research to be done on making sure that we know exactly how to use it. And why, in my opinion, research is still not meeting the expectation of PRP is back to all of these studies are being done differently because the PRP is being prepared differently. It's either maybe a single spun centrifuge versus a double spun centrifuge, which makes, and I'll kind of get to that towards the end of this part, but how the PRP is being prepared is going to affect the study. And so if it doesn't work in the study or isn't as helpful, you go back to the methods and you find, well, they didn't prepare it right. They didn't get to that therapeutic dose. And so of course you're not going to have the results that you want. So before we get to that, what we're finding is it absolutely can influence these conditions, but you got to do it a certain way. Conditions being knee osteoarthritis, rotator cuff tears, Achilles pain, plantar fasciitis, even hair loss or androgenic alopecia is something that it can even help with. So we have a large amount of research. This was a huge meta-analysis of RCTs comparing PRP to corticosteroid injections for both knee osteoarthritis and rotator cuff. They found PRP in this body of research was more effective at actually reducing pain and improving function in short and intermediate term follow-ups comparative. Wow. And again, kind of like I just said, we do have a decent amount of research showing PRP can be more effective than steroids in certain settings. And again, why is that helpful? Because it's your own, it's natural, you don't have to worry about the side effects of cortisone, and it's a cheap process if you are doing it the way that, at least getting to therapeutic dose. Let me backtrack because I don't want to confuse anybody, but what you'll find is if you want to do it the right way, the clinic has to buy a lot of technology in order to get the proper outcome. So you might have cases where providers just have to pay for a $200 centrifuge, and they put the vial of blood into the centrifuge, they spin it once, they draw it out, and now it costed about $100, and they can charge a certain amount for the PRP. In some cases, it might be helpful, but when you have the tens to $30,000 of worth of technology to actually get the right amount of PRP and to measure it, because not only is the proper centrifuge needed, but the proper platelet counter is needed. And those are separate pieces of technology. Okay. And the platelet counter will help you get to from what I've been reading, you have about 100,000 to 450,000 platelets per milliliter, microgram platelets per milliliter. And what you'll find is you need at least 5 billion per milliliter to get a therapeutic dose. Okay. Not 1, not 3, but 5. And if you don't have that, then you're not going to get the results you want. And the only way of knowing is you have to measure. You have to take the small amount, put it into the platelet counter, and it gives you measurement per milliliter. And that is something that is absolutely going to be needed in clinics if you're going to have great reciprocity between patient outcomes and measurement. So those that are charging a higher amount are doing it because they have a large amount of costs involved to make sure that you're getting the right outcome. So it should be, hopefully one day, more affordable if this technology can start being less expensive. But right now, if you are getting PRP at a smaller price, I just want to make sure that you guys understand asking these questions. Do you have this technology? Are you measuring? What are you doing in order to get the outcomes that you want? Because I think if you're going to pay any amount of money, you want it to be done appropriately.
Yes.
So,
which makes sense on why it's probably really hard to regulate, because
Right.
like it's either you can spin it out, you can have who knows how many platelets from the blood that you just spun
Yep.
to go back in, or like you said, doing it the right way and knowing the proper therapeutic dose and making sure that you're getting that. And that would even make sense for people later on in life. And that's oftentimes the population that needs it more.
For sure.
Which, if they're just going through the motions and it's cheaper, you're probably not going to have the right effect.
yeah.
So
And,
you almost have to spend the
if
money.
someone is grateful enough to charge a low price, having all that technology, heck, that's awesome. You take advantage of that.
Oh, yes.
But what you'll find is, of course, with healthcare, you want to make sure that you continue to run a proper, healthy business that isn't losing funds. So you want to make sure you're going to charge appropriately for it. So, but yeah, back to we're finding in the research. We have comparative studies of PRP to corticosteroid injections for rotator cuffs, for Achilles injuries, for plantar fasciitis, even comparing medication versus hair transplantation for alopecia. PRP has been shown to be just as effective. Again, more is needed to be done, but what we know is PRP has been shown to promote faster healing. It can even reduce the risk of degeneration, accelerate plantar fascial healing, improve foot function, stimulate hair growth, prolong the anagen growth phase of hair cycles, enhance hair quality, even the appearance of hair compared to conventional treatments and surgical interventions. And that's, I would say, the major 6 things that even we know right now that I would be comfortable doing on patients comparative to corticosteroids or medication.
Man, that blows my mind. It's like almost a therapy that it's almost worth its weight in gold. Yes, it costs a little bit, but I guess where are some of the things that we need to make this more widely spread other than research and
Yep.
other than costs
Yep.
diminishing?
Yes.
I'm sure education, but is there
Yeah,
anything else?
education. I think making sure we have uniformity between protocols, like we had talked about.
Smart.
There are great practitioners out there who have done the work clinically to show their outcomes and why they are choosing this certain billion per milliliter, 5 billion. And there are still studies out there where that therapeutic dose was never reached in the methods, but had good outcomes. So it's not to say that we still maybe need to figure out what that dosage per milliliter is so that we know effectively what to get to. And then, of course, when we have more demand, there's more supply of this technology, those costs can come down and more clinics are able to have this at a more affordable price. So again, understanding therapeutic dose is huge. Understanding when to use leukocyte rich versus leukocyte poor. Obviously, if you're in aesthetics and you don't understand this and you're putting, therapies, single spin versus double spin has been early on a large comparative argument where if you single spin, what they say is your ability to concentrate platelets is still not as effective as taking that and then double spinning it.
How long does it take for each spin?
About 10 minutes.
Okay.
So what a lot of people do is they actually separate. You have the red portion of the blood, on top of it is the yellow, which is the plasma. They actually take the plasma out, put it into a separate syringe, and then spin it again.
In a separate
So
tube.
you're even getting a higher amount. And then what you'll find is platelets are heavier now in the plasma than other properties in the plasma, and those platelets are going to sink to the bottom. So you'll have red blood cells, white blood cells, other properties sink in the first tube. You take out the plasma, now just the platelets are going to sink to the bottom in the second tube. And so what you'll find is, let's say you have 5 milliliters left over of the second, you can draw off the first couple milliliters, waste, and now you have the highest amount left over, about 3 milliliters, pure platelet-rich plasma with nothing else in it.
Wow.
And that's where you're going to have a better ability to concentrate as many platelets as possible.
Fascinating. So time then plays a factor into this.
And if you're going to get
protocols,
get high amounts of platelets in a concentration, you're going to need to spin it twice.
which would make sense.
And you're going to need to take a large amount of blood to get it where you want it. So a lot of people are taking, let's say, a small tube of maybe 10 milliliters, spinning it twice and getting a small amount of platelets. But some of the clinics that are doing it properly, in my opinion, are taking 3 to 4 large vials, 60 milliliters of blood, transferring it all at the same time, then to a smaller tube, spinning it again, and getting this incredibly high amount of platelets as far as getting a therapeutic dose.
Wow. Okay, so let's say they take all this blood, they spin out, so we have, like, let's say a double spin
Yep.
of platelets. Are they able to store that, or do they have to utilize those platelets in a certain time frame then and there?
I don't think I've heard of any storage mechanisms for PRP, and maybe I'm wrong, but what you'll find is that most likely will be needing to be used within 30 minutes.
Okay.
Because there might still be clotting properties in that PRP, and if you let it sit, it will clot. And we obviously don't want anything like that to happen, again, for thromboembolisms or any other things like that. That is going to be something that's going to be used right away.
Fascinating. Okay.
Yeah, so
Absolutely.
that's
So
where I
cool.
think we're going to get better understanding of this, is if we actually create better protocols, guidelines for use intravenously and locally, and that's where we're going to start to get it dialed in. And I think that's where more people are going to become comfortable doing this in clinic, is knowing what to do. Because a lot of these providers don't want to be the trailblazers. They just want to know, all right, what do I got to do? What does it got to look like? And how can I get my patients better? And it's fair. That's exactly what needs to be done for proper use across, widespread use.
Yeah, that's fascinating. When I look at it from a chiropractic standpoint on the proper dose or frequency, like we have some studies that have come out in a general sense of a long-term approach, and we've touched on that last week. But God, and the profession's been around for over 120 plus years. Like,
We're still trying to figure it out.
Exactly. I can't even imagine you accelerate this whole process and the protocols and the methods. There's so much upside to this that is probably yet explored. Obviously, cost is one thing, but man, there's so much potential here.
Yes.
I'm so excited on just PRP itself. So, Doc, when you brought up the platelets at the first few stages of healing, and then you just reiterated that stem cells then come in from stages like 5 and 6, it would make sense, and there would be an order on which treatments you receive at certain times. So stem cells, let's dive into those. What are stem cells?
For sure. So we all have stem cells in our bodies, and stem cells, from what people think stem cells are, is they turn into something versus what they actually are is they recruit cells that make things. So a lot of the times providers still need to get this right. If you're a provider saying this to your patient, do stem cells, you need to change your phrasing right now. Stem cells do not turn into damaged bone. Stem cells recruit osteoblasts, and osteoblasts create the cells that create the properties to heal bone. Not only do they do that, they recruit chondrocytes that create cartilage. They recruit adipocytes that help with fat repair. They have tenocytes, which create That's what stem cells do. They're coaches. They come in and they say, hey guys, game plan. You got to go heal this. You got to go heal this. And I'm going to die in 3 days. So you guys got to get this right, because I'm not going to be around for long. And that's what a lot of providers too. They tell them, how long are stem cells alive once you inject them? And they'll say, oh, it's months to years, right? No, that's a lie. We now know that they're there for hours, maybe days. Okay. And so the actual benefit of stem cells is that they can create this kind of rally, and they can do it in a short amount of time. It's whether or not your body creates enough hype to start that cascade of healing. And stem cells do a great job of doing that. So stem cells are really the huge rally coaches that come in and tell what cells need to start healing what, based upon what damage you have in the body.
Okay. I love that analogy too, because it makes way more sense. And what stages to go at in terms of regenerative medicine, platelets, then stem cells, and just even learning that the stem cells are precursor cells to allow other properties of the body to signal for healing to occur, more or less.
And like you had said, the stages, right? So we know right away platelets are what do a large amount of healing properties. Now it's then when stem cells are recruited after to kind of finish the job. So plasma, blood, platelets, they all contain, anti-clotting factors and cytokines and all the things that do a great job of stopping the damage as soon as possible.
Yes.
But there needs to be now some type of rally to start repairing and regenerating what was stopped as far as damage was done. So let's say you have a bleed, platelets come in, clot it, stop the bleed, but now we need to repair the vessels, and we need to repair the other tissues that were involved that were maybe caused with as far as the damage was done. So let's just say, for example, you nicked part of your skin, which maybe was deep enough to nick superficial veins, arteries, or whatever. Platelets are going to come in, stop that from bleeding. For sure, it's going to come in and do that right away, try to get that from stopping. But now we still have a lot of damage to the other tissues of fat, skin, vessels, what have you. Once that's done, stem cells are now recruited to try to finish the job.
Fascinating.
Now, where research needs to start being done is the multimodal approach of stem cells and platelets. And what we always did, and we found way, way better outcomes, was using PRP first, and then we would let the body do its job for a few weeks, 4 weeks, and then we would introduce stem cells about a month later. So we would do a round of PRP maybe once a week for 3 to 4 weeks. After that, we would then do the stem cell injection. And we found that to be way more effective. And there are few studies that actually show better outcomes using PRP and stem cells together. But we have way more research that needs to be done to truly prove if that's the best way to do this. But experience-wise, by far, if I'm going to do stem cells, I'm going to do platelets before stem cells, in my theory, in my understanding, and what we were able to do as far as outcomes.
And with your experience from, would it matter acute injury, like you just nicked the skin, like you said, there's some damaged tissues with that, versus a chronic condition? Would you go about it, I would assume, in the same order, but does that change the frequency or the timing frame from what you've done with patients in the past?
Sure. So if it's acute, a lot of that pro-inflammatory component, it's probably already started. So in theory, you could probably go with stem cells right away, or you could go with platelets right away to continue that. It's still a lot to be learned and a lot to understand on that process. But as far as like skin and wound healing, PRP is now actually starting to be accepted as one of the best ways to heal wounds. Okay. And there are even, we'll get to this later, but another great component to that are exosomes for wound healing. And exosomes, like I said, are what are also contained in that plasma. And so it makes sense that PRP works so well. But as far as healing goes, you're going to have use of platelets and you're going to have use of stem cells. So no matter what, you're probably checking off those boxes of healing if you're going to use one or the other. And at whatever stage, it's tough to predict. But in my thought process, if it's chronic, we need to reset that healing phase. And if we're going to reset it, we got to go back to the beginning.
Smart.
And that's going to be starting with platelets.
Smart.
So when I look to restart the healing process of something that's super chronic, I'm going to start it with platelets because I know in theory it's where that's going to get started. Platelets are going to start it up. So I want to reintroduce first is going to be platelets first. Then I will introduce stem cells. And I'm almost going to do that for everything. But again, this is just my experience and my theory. We still have a lot to research to be done on it.
Fascinating. I have so many questions, but I think it's also best to understand, okay, well, the stem cells came about in a direction and in a way. How did it come up? Because it's best to understand where we were to where we're at right now to know where we need to go.
For sure.
So I guess, when was it first done? What were they trying to do? And obviously where we're at right now, we need more research moving forward.
Yep.
But how did it look previously when they first tried some of these therapies?
Yes. So
stem cell.
what most people don't realize is the first stem cell transplant was done in the 50s.
Okay.
And it was done on leukemia patients. So we know that we have a large amount of stem cells in our bone marrow. What can happen though with leukemia is we can get cancer in the bone marrow and it'll spread. So what this was done on was patients that had infected bone marrow infected stem cell bone marrow. And what we did was we radiated the body, and that killed all the bone marrow. That's what radiation can do. What then they did was introduced a donor healthy bone marrow, and that actually then started to proliferate through the bone marrow and create a healthy bone marrow.
Wow.
And that was, now this is something that's done on patients with leukemia, bone marrow transplants, and it can be effective. And that was done in the 50s. So we were doing stem cell transplants since the 50s. Now it wasn't quite taken off in the orthopedic space maybe until about the 90s. And so that was the first what are called mesenchymal cell stem cell transplants. And before I get into that, I think I want to make sure I break down what the difference of stem cells are for most people. So
Smart.
when you take a look at stem cells, you can kind of branch them into two types of stem cells. So you have embryonic stem cells and you have adult stem cells. And embryonic stem cells are what are used to grow a fetus.
So like the placenta.
Yes, placenta, all of the cells
umbilical
involved in
cord,
growing a
sure.
fetus.
Okay.
Now, the word totipotent, pluripotent, and multipotent are ways to describe stem cells. So the only totipotent cell in the body is the embryo, the zygote. It's totipotent, meaning it can actually create any cell in a human body, including extra embryonic cells like a placenta. It's the only actual large zygotic cell that can do that. That's it. So when it comes to creating any cell, any tissue, anything at all, the zygote is the only thing that can do that. And it's an embryonic stem cell. Now, you have, actually I don't even know if you'd phrase it as a stem cell. It's a cell. It's a totipotent cell. Now you have embryonic stem cells, and those are the cells that go on to create any tissue in the body aside from the placenta. The zygote is the only thing that can help with the placenta. Other embryonic tissues that can create other cells would be like the cells that they create IVF. So IVF cells, those can be embryonic. A lot of the ways that they got embryonic cells for research were by donated IVF cells that were taken and not needed for implantation. So let's say you did IVF and you had too many cells. You were able to create too many viable cells because they're only going to implant so many. Because if they implant too many, you might get there have been side effects of having triplets or quadruplets, and they don't want to do that. So they'll donate the actual leftovers to research. But what was done in the early maybe 1990s to 2000s was a lot of embryonic research, and I'll get to that, and I'll tell you why safety of stem cells, there's a lot of misconception around it. So embryonic is that, and then you have adult stem cells. These are hematopoietic or mesenchymal. Now, hematopoietic comes from umbilical cord blood and bone marrow. And these hematopoietic stem cells are the only FDA approved stem cell products. So for leukemia, especially, or other types of hematopoietic properties. But where a lot of research is being done right now is on mesenchymal stem cells. And you can get mesenchymal stem cells from so many things, including, and I'll just name a few, but fat, bone marrow, Wharton's jelly, breast milk, menstrual blood, dental pulp. You can even get it from your ligamentum flavum, your placenta, umbilical cord vein, even from your blood. Platelets. You can get it from a lot of things. So you want to make sure that understanding why mesenchymal cells are more safe is because they're multipotent. And multipotent means they can only turn into so many cells. They can only turn into fat, nerves, chondrocytes, so that's cartilage, muscles, bone, that's it. They can't turn into other properties. So let's say, let's just say in theory you got a totipotent cell that could grow into a different type of tissue that could maybe then turn into a tumor. You don't have those properties with mesenchymal cells because they can only turn into so many things. So your chance of them forming into something you don't want to is very limited. Because they can only turn into so many things. And that's why mesenchymal stem cells are now the more forefront as far as stem cells being used, because they're the safest. They have very little chance of turning into anything other than those 5 or 6 things I just said.
Yeah, when I hear stem cells, I know previously, this is years back, I hear about stem cells. It can be good, it can be bad, but there's other tumors that can come up with it. It makes sense on the difference now between those two, and only the certain properties that it can turn into. It makes way more sense now, which I think once we change the education of not only providers but the public, it'll only let the guard down even more.
And so again, the first embryonic stem cell treatment that was done in the 1998, that was kind of shut down. They just found that there was really no need to do a lot of embryonic stem cell research because they found that mesenchymal stem cell, hematopoietic stem cells were more safe and effective. And so I don't think they've even done embryonic research anymore. I don't even know if they're still doing it. So, and back in the day, there was such a misconception was because they thought they were taking aborted fetuses and taking those cells to create research. But a fetus is not an embryonic cell. It's the cells that create the fetus are what they were using.
Makes sense.
Again, donated IVF or any of the ways that they were using those in research. So it had been donated in a way that really wasn't even a formed zygote yet. And so, but again, there was just no need for it. So it's not that we were taking these aborted fetuses using the cells for research. It was what was about to become that. And we kind of shut that down. And it makes sense because there really is no need. So the ways that we get more or less mesenchymal stem cells now is by fat, bone marrow, or umbilical cord donation. Those are the three major ways that we're getting mesenchymal stem cells right now for research.
Does that have to line up? Because I know, like, if we're implementing other people's blood, we have to match up O positive, negative, AB, what have you with that, just so your body doesn't reject it. Is it similar? Are we getting it from our own body, or are we getting it from donors, or how does that look like? And how do you break apart the difference between the stem cells and platelets? What is the difference between getting those properties?
Good point. So with PRP, it's always going to be autologous, meaning you're going to get it from yourself. I don't think they're, other than, of course, a lot of people don't realize is when you donate your plasma, most of that goes to cosmetic companies, and because it has healing properties, right? So you can use other people's plasma for certain things, but it's got to be screened, make sure there's no disease, like there's all those kinds of things, and make sure the proper testing is done. But if you're going to have something injected into you, you're going to make sure that you don't have the rejection properties of similar blood types, because that can absolutely happen. And same thing for bone marrow. So you're going to make sure that all of the things align before that transplantation happens. So right now, other than leukemia, all of the orthopedic type things on PRP, bone marrow, and fat are all done from yourself. So the fat extraction is done on you. The bone marrow is done on you. The PRP is done on you. And that is where you're going to have way less forms of rejection, and you're still going to have good effective property outcomes.
Man, okay, so, and I know, probably jumping ahead a little bit here. Let's say, God forbid, you would have cancer, but you want to bring stem cells not from yourself for the healing to take place. Would that be true for certain cancers?
So
I
just want to make sure I'm getting your question right. Can you still do this therapy if you have cancer? Is that your question?
Yeah.
Okay. Yeah, and this is where in the late 1990s and 2000s there was such a pushback, because you had these providers that were doing some pretty incredible things that unfortunately the United States put a kibosh on. Now, basically what happened in the 1990s and 2000s, what we had was stem cell research had been gaining a lot of traction, but there was a lot of ethical concerns, like I talked about with people not understanding that it was not fetuses, it was embryonic cells that were being used. But some of the pioneers of stem cells were actually manipulating cells. And they were, we can jump to exosomes in a little bit too, but in order to get an exosome, exosomes come from all cells. They come from the cell. So if you have to take a cell, you have to squeeze it, out comes an exosome. But that manipulation, according to the FDA, is now a drug. When you manipulate a cell, it's now classified as a manipulated cell product, and that is a drug. And if you manipulate something, it creates different properties. It almost primes it now. And that priming is worrisome because now you primed it to do something that we don't know, and we need to regulate what that's going to do in the body.
Makes sense.
And so that's the difference between what's called a 361 human cell tissue product and a 351 human cell tissue product. A 351 is, or excuse me, a 351 is considered more than minimally manipulated. And so it's intended for what's called non-homologous use, meaning homologous is basically you take something that, let's say Wharton's jelly, which is just jelly that lines the umbilical cord, and it's used for cushioning. You take the Wharton's jelly and it's used for cushioning. So it means you have to use it for cushioning in your body. And some of the ways that you would use cushioning is in a joint.
Makes sense.
So you take the Wharton's jelly, you put it in the joint for cushioning. It's a homologous use now. You don't have to manipulate it, and you can get away with not having to do certain drug trials, pre-market product, because it's homologous use. So under 351 human cell tissue product, it's more than manipulated. And that is, unfortunately, exosomes can fall into that because you have to take cells and manipulate them to get the exosomes out.
Okay.
And that's where they're arguing right now whether exosomes need to have FDA regulation, basically. There's a lot of argument and pushback with that. So as far as stem cells go, Wharton's jelly, if you take the Wharton's jelly out of the umbilical cord, you don't do anything to it, put it in a vial, freeze it, send it to the clinic, they take it out, unthaw it, put it in you. There was no manipulation. And it's a 361 product, meaning minimally manipulated. You don't need any what's called an IND or an investigational new drug application where you're going to have to do trials and go through all 4 phases of those kinds of things. And if it's homologous use only, you don't have to do that. So this is kind of going down a rabbit hole, but there's a lot of understanding that needs to be done before we move forward with this for practitioner use, for patient use. And right now in the laws, if you are a lab doing this and using these products, if you are not doing manipulation to the cell, it's technically a 361 product. No IND or trial is needed, stated by the FDA, and you can use it homologously. So if you don't do that, if you manipulate it, technically you need to have an IND and you need to have the proper trials being done in order to put your product in the market.
Which takes time.
Which takes time and takes money.
Effort, all that.
And that's where a lot of these companies are trying to argue that you can minimally manipulate the cell to get the exosome. But what kind of manipulation is subjective and up to now the FDA's regulations? And that's going to be the next 20 years, 10 years of arguing what is manipulated cells. What are technically manipulated? What does manipulated mean? So in the 2000s, they were manipulating cells to try to get exosomes, try to prime them, try to get them to do different things. Dr. Riordan was a kind of a pioneer of this. He would take, this is crazy. He would take, so back to the entire point of, can you do this on cancer?
Yes.
He would take your cancer cell you had in your body. He would culture it. He would then take your bone marrow, put it in the culture. He would prime it to put anti-cancer properties into that bone marrow. He would then take that, put it back into you. That now has anti-cancer fighting properties to kill that cancer or to eliminate it. And this is what was being done. It was, we would take what was ever done or wrong with you, we'd culture it, and then we'd take your own stem cells and we'd prime it against what was wrong, and then we'd put it back into you, and it would have the ability to fight off what was wrong. They were doing this with infectious diseases. They were doing this with MS. They were doing this with autoimmune issues. They were doing this on nerve cells. They were doing it on tendon cells, muscle cells, all of these things. So think of it like this. Think of it like muscular dystrophy, muscles that have inside of them this property to break down. They would culture it, put in the stem cells, prime it against that, and see if it can't regrow those muscular damaged cells.
Locally and systemically?
Yes.
Oh, God.
Now, all that manipulation was regulated, saying that we can't have this, because what if those primed cells turn into a tumor? Which makes sense.
Yes. Safety.
So
Yep.
we needed to make sure to understand that before we were going to do it in the United States. So yes, I completely understand that. But what they're doing now is outside of the United States, we're still doing this. Dr. Riordan, he moved to Panama, and he's still doing all these studies. And he's doing the proper research himself. He's making sure that it's safe. But he's doing it outside of the U.S., which requires less regulation to do these kinds of research. And so the answer was yes, you can. And there's more and more research going to be coming out against priming these cells, manipulating them to actually have anti-fighting properties for what you need to use them on. And that is the future of cellular medicine. It's going to be incredible.
Crazy.
What you're going to find is a lot of people are saying cells are the new drugs. That's what they're going to find is if you have a cold, a virus, or something, they're going to take that virus that they think you have, they're going to put it in a culture, they're going to take your cells, put it in there, that cell now becomes medication for you, they're going to put it back into you, and they're going to fight that off. That is going to be the new medication. That's where they want to take regen medicine and cellular therapy to the next level within the next 20 to 30 years.
Body can absolutely heal itself.
Yes.
Just a little bit of tweaking.
Right.
Dude, oh, God. I had no idea. Well, certain ideas, but that just opens up so many possibilities, which also makes sense on why when we've been going through this for 20, 30, 40 years, give or take, and how it's taking this much time because of the regulation, obviously. Safety, like we said, it's the most important thing, but wow. Okay, so, because I know you brought in mesenchymal, whatever you want to call it, those cells, and let's say we want to add that in, like those stem cells for regeneration of nerves, tendons, ligaments. I guess what are the benefits and properties to tweaking the cells that you already have?
So great point. And I'll quickly kind of go over this because I don't want it to be too lectury. There are really 5 main benefits of mesenchymal stem cells. So they have the ability to have multipotency, which is what we talked about. They're multipotent, so they can turn into fat cells, they can turn into chondroblasts, osteoblasts, all the types of cells that then turn into the properties of which they are. So again, adipocytes turn into fat, chondrocytes into cartilage, tenocytes into tendons, osteoblasts into bone. And they know what to recruit because they have this kind of homing migration mechanism built into itself. So they can move along blood vessels and even pass through endothelial walls to actually home into where the damaged and diseased tissue is. So that's their second property. They have a homing migration mechanism. And so we still are trying to understand what they can actually get through, which tissues they can move through to get to the damaged property. And we're still trying to understand how that all works. But third thing is they have trophic function. Trophic is just another word for growth factors, cytokines, chemokines, all those kinds of things. And so they have the ability to, stem cells can release those on their own. They almost have an immense amount of toolkits and tool belts built into them. So they can come with all of that inside of them, get close to the area, and then release growth factors.
I like how you said that.
So they're like huge vessels that contain properties to get to that area. They're like little homing bombs of healing.
That's cool.
And so they can get to that area, release the cytokines and the chemokines and the other types of vesicles, exosomes included, to get to that area, to start to recruit, to message, to talk, to get this damaged tissue to start being rebuilt. So they have trophic function. They do have the ability to suppress the immune system if needed. So there are immunosuppressive function. Let's say that something is obviously something, there's a immense amount of immune reaction happening, pro-inflammation, those kinds of things. Or if there's just an uptick in your immune system from, again, things that can cause your immune system to kick in, which would be like a virus or even autoimmunity, those kinds of things. It can downregulate that or upregulate it if needed. So if you have hypoimmune, so if you're immunosuppressed, they have been shown stem cells can actually upregulate the immune system if needed.
Fascinating.
I think the word that I would want people to understand is it's a modulator of the immune system, meaning if it's high, it'll help it get to middle, or if it's low, it'll help it get to middle. And I think that's a beautiful property that needs to be studied more about stem cells if someone is either immunosuppressed or has a hyperreactive immune system. Well, we have way more research that needs to be done on that. And then lastly, it has proliferative function, meaning it can actually proliferate into other things. So it can go and turn from a stem cell into a chondrocyte and then create more of it by itself. So it can duplicate itself. And that's another important factor if you want to have more and more of them to duplicate, proliferate. So those are the 5 main things that it can do. And where it would be used is exactly, I kind of already explained it as far as the benefits go, but anything that needs extra healing, anything that's damaged, anything that, it has a need to repair or regenerate, stem cells are going to be a part of that process. And so when you can create a high amount of them in a small area, like we said, concentrate them, put them where they're needed, you just have a greater ability to heal that area.
Which makes sense.
In general.
God.
But as far as what's being used, we have so many things that it's being used for. Anything from just orthopedic conditions, that's only one part of the puzzle. We have heart studies, liver studies, brain studies, immune issues, autoimmune. There are a lot of things that stem cells are being studied for that are showing some pretty impressive outcomes, but we're going to need another 5 to 10 years before we really start to understand their capabilities. But one study I know was kind of put on the forefront a while ago was these patients that had a heart attack. They were given an intravenous infusion of stem cells, and over half of them actually showed a reduced or even limited amount of heart cell death because they were given stem cells after that heart attack. And it actually had heart protective properties to limit cell death from heart attacks. And so again, cellular medicine, it's like, and where I think it's going to be really impressive as far as where I like to put a lot of my time and effort is into neurologic diseases. They're doing this post-stroke. So post-stroke, doing an intravenous and just showing the neuroprotective properties if you've had a stroke or post-traumatic brain injuries. So if you had a huge whiplash concussion, getting an intravenous infusion of stem cells to actually protect cell death in the brain. Wow. And then of course you have liver studies showing if you have liver cirrhosis, which is a kind of a disease of breaking down, the liver is starting to become very hardened and breaking down, usually from alcohol use or other types of diseases. It's actually protecting liver cells. And so again, the protection, in my opinion, is just because they're healers and they're trying to reduce the damage being done from the properties that are why it's being damaged, whether it's cell death from ischemia, stroke, heart attack, autoimmunity, all those things. They are the reasons why the protection and healing is being done.
So when you go and look to have some of the stuff done for like the liver, the heart, intravenously, would you then just bypass platelets itself and go straight to stem cells?
For sure. And this is still where we need to know whether platelets are a good component to starting this process off, or can you skip that process over and go right to stem cells, which a lot of those studies don't use platelets. They just use stem cells, and they're finding great results. So we still need to know when and why and how and what to use together, what not to. It's all theory right now. But again, we do have platelets in our body that are probably already being used to heal things when this damage is occurring. And so when you're introducing stem cells, again, that's already adding to what's probably already going on in your body. So the question is, which conditions, at which time is it better to maybe introduce platelets first, then stem cells in a concentrated form? We still have research to do on that.
My mind's blown. Like, I had no idea half this stuff could help, especially stem cells with the liver, the heart,
lung,
the
COPD,
system,
all these. I mean, you name it. Pick a part of the body. They're researching it.
That's crazy. I know you brought up earlier that why you would want to manipulate a stem cell, and Wasn't there a person that won like a Nobel Prize a few years back?
Yes. So this is by far going to be my favorite part of the podcast.
Cool.
Because I think this is going to be the more fountain of youth, like really where I think we might start to gain some crazy traction on stem cells. So Dr. Yamanaka, he was the researcher who actually created the first induced pluripotent stem cell. So again, pluripotent was the ability to change into many, many, many cell types without placental cells. What he was able to do was take any cell in the body, not a stem cell, any cell in the body, and through what was called the Yamanaka factor, using certain gene expression changes, he could turn any cell into a pluripotent stem cell. So think of it like this. You have a damaged cell in your body. It's not helping right now. It's dying maybe. If you included or introduced the Yamanaka factors to this cell, it turned it into a pluripotent stem cell. You basically just reversed its damaged state to a pluripotent stem cell. And that stem cell now can go about and start making change to tissues and turning it into, again, what we talked about, a healing, fighting warrior stem cell. What does that mean?
Oh.
It means, can we now start reversing aging? Can we now start reversing death in organs? Can we now start introducing these factors to these damaged, almost dead tissues and get them to be true, healthy stem cells again?
Did they do this with nerve cells? Because
They did it with, you can do it with anything. Any cell. That's what was the Nobel Prize. He can do it to any cell.
And that was what, back in 2012?
2012.
Which
So
is
again,
a
this
little over 10
is
years
new.
ago.
I mean, this is incredibly new.
Oh, you
But
had
he now
20, 30 years.
revolutionized stem cell research. And this was so groundbreaking because now we have possibly the ability to reverse cell death.
God, I got goosebumps right now. Fucking hell.
And we don't know where this is going to go. But now, do we have the ability to never kill a cell in our body? Are we going to live forever? I don't know. But this was by far one of the biggest groundbreaking finds in stem cell research. Why it was also so groundbreaking is because, from what we remember, pluripotent cells were embryonic cells.
Yep.
From embryos. That's the only way we were able to obtain those pluripotent cells, was from that process of embryonic cells. And it was just too cumbersome. We didn't want to have to take a donated IVF cell or anything because it was just kind of ethically just challenging for us. Because technically that cell could have turned into a human. And I think that's what was tough for us.
Makes sense.
So instead, he now was able to take a cell, adult cell, and turn it into a pluripotent cell without the need of embryos. Now we don't have to even go down that road anymore. And that's another groundbreaking change, to know we now have the power of embryonic cells without actually needing embryos. We don't have to do that test tube research anymore. Test tube babies, that's not what we have to do anymore. And that's the incredible feat that he was able to create.
I can't imagine adding 30, 50 years to that. Oh, Lord. Man, have science improved and accelerated. I've never even thought I would even hear those words like the fountain of youth or reverse aging to live longer.
Right. Who knows what the next 100 years are going to look like.
God, that changes everything.
Right. So
I'm
super excited for the future of cell medicine.
Wow.
Seeing how cells might be the new medicine, the new drug, just all these things. That's what's really exciting for me.
My mind is blown. Okay, so I want to keep things moving because my mind's still blown thinking of the possibilities. But I know we wanted to bring up exosomes and how much they're manipulated to be FDA approval. So let's say that they're approved, or if we have to go outside the country, I guess, what are exosomes? How do you get them?
Yeah. So think of exosomes as the assistant coach.
Okay.
So the head coach was the stem cells.
Cool.
However, let's say the head coach can't run across the field. So he uses exosomes, the assistant coach, to go and run across to reach the players. So exosomes are the cell communicators. They contain nucleic acids, they contain lipids and proteins, all the things that they are able to transfer as far as messaging to other cells. They really are just talkers.
Okay.
And so why stem cells can do what they do is because when they need exosomes to recruit chondrocytes and other osteoblasts and other things, they are the little vesicles that go about to exchange information. So think of it as the stem cells whisper into the exosomes' ear, hey, we need more bone in this place. Exosomes come out through transfer of information. They say, hey, stem cells just told you guys to come over and start building more bone. And that's really what exosomes, in kind of a more brief understanding of why they're so helpful and what they do. So they're also small. They're incredibly small. And why you would maybe want to use exosomes instead of stem cells, what we know, two major reasons I would put exosomes into use versus stem cells would be, one, they don't create an immune response.
Okay.
They have low immunogenicity. So let's say you had someone who had a high immune system reaction, autoimmune.
Okay.
They can come in and talk to cells that need to help heal without stimulating this hyperactive immune response that maybe patients can have. So that would be one theory of research that they're trying to understand if exosomes are more helpful than stem cells.
Okay.
Another is they can cross the blood-brain barrier. So they are small enough to cross the blood-brain barrier to get to the important cells in the brain that need to, again, be communicated to say, hey, this is what's going on, this is what needs to heal, those kinds of things. So that is where I think you're going to find, as far as healing properties, conditions, that's where they're looking at right now. And there are some other things I think I'm not quite bringing up just because I don't want to get down that rabbit hole, but those are some of the maybe more different properties of exosomes. They also don't have the main mechanisms that stem cells do. You know, they don't proliferate. They don't change into anything. They're just communicators.
Okay.
So, but what they also, and this is where there's going to be a clash, in my opinion, of the modern medicine and those trying to do cell research, is they are incredible at delivering things. Meaning, if you can take a drug, stick it into an exosome, you can now deliver that drug way more efficiently. And that's what they're finding. They are probing and having drugs being delivered by exosomes way more efficiently than just having you take a drug orally and then having it get through the system. So they're priming the exosomes too, but they're doing it with a drug. They're putting drugs on the exosome, and the exosomes are getting it to your body way better than just taking it orally or just basically injecting the drug into you in a certain other way.
I wonder if that will have less side effects of that drug locally, and that's obviously tough to say, but...
So now you're going to have pharmaceutical companies interested in exosomes because they're way better at getting drugs to the areas needed.
Better effects. The research would probably be swayed to a certain extent, of course, but that changes a lot of things as well. So like when you look at stem cells versus exosomes, would exosomes be more given like intravenously for the systemic approach, or would that also be given locally? Good
question. So we still are starting to come around with more exosome research. We don't have a lot comparative to stem cell research, but already we are seeing exosomes being used similarly to stem cells. We have some research on knee osteoarthritis, exosomes being injected and getting good outcomes.
Wow.
So again, we are starting to see benefits of exosomes being used similarly to stem cells. I think what it's going to come down to is, why would you use stem cell versus exosomes? We got a lot of work to do when it comes to that. But what you're finding right now is, most of the time, like I said before, if we need to get exosomes to the brain, or if we need to get in past the immune response, or if you don't want to elicit that immune response. So exosomes are really great for wounds right now.
Okay.
Because you're not adding that extra, like we talked about with the leukocyte poor plasma. You don't create that extra pro-inflammatoriness. Exosomes don't do that. So you can put those on the skin and it doesn't create that pro-inflammatory effect. And you can still get the healing properties from it. So you're finding a lot of aesthetics, wound healing places are using exosomes because it can create such great healing responses and not have those adverse effects of a pro-inflammation.
Just bring the whole coaching staff then.
Yeah.
Head coach, assistant coach, let's go.
And you'd be surprised at some of the things exosomes are doing. I mean, exosomes are starting to replace Botox and fillers because they don't have the adverse effects, and they're getting the, you're seeing it on wrinkles. You're seeing it on even adding volume where they're putting it in under the eyes, tear troughs. They're doing fillers. They're doing, that's not my space, but we would be surprised at some of the things, even post-operatively. So let's say, you had laser done on your face, or hair transplant. They're using exosomes post-operatively to actually reduce the effect of surgery. Having that puffiness and that swelling and all those kinds of things is actually eliminating that.
Wow.
And so you're seeing it on that. If someone has a lesion, an ulcer on the skin, you're seeing that skin heals sometimes 2 to 3 times faster without the use of those exosomes.
Wow.
It's diabetic ulcers, which if you don't know, diabetic people just don't heal very well. Exosomes are being put on those ulcers and they're healing way quicker than what diabetics could have done themselves, because they are poor healers. The things that we're going to start to see come out, still, it's going to blow people away when we start to get more research on these products.
I would love to incorporate this, and I know there's probably not studies done in terms of PT and rebuilding the structures of like arthritis, degeneration, combating possibly even surgeries for limb replacement, shoulder replacement,
For
knee,
sure.
all that. I guess, is it FDA approved? Where would you typically look if you wanted to get exosome therapy done with maybe a combination of other therapies? Would it be pain clinics? Is it available in the US?
Yeah. So right now, as far as FDA approval, the only approval is for hematopoietic stem cells on leukemia and lymphoma and those kinds of conditions. So there is no FDA approval for the use of stem cells for orthopedic conditions, neurologic, anything. There isn't. Even exosomes. Exosomes have none. We don't have any. So yes, now I want to make sure people understand this. Just because something isn't FDA approved doesn't mean you can't use it. And that's where a lot of people get worried is, well, it's not FDA approved. So where a lot of clinics are struggling or even getting letters from the FDA is because they're claiming it can help certain things. So come get stem cells for this. That is illegal. If clinics are claiming anything, if clinics are marketing anything, I know it's difficult to get patients in that door, but you cannot legally do that.
Okay.
What you can do is, let's say you have patients in your clinic having, let's say, knee pain, knee osteoarthritis, and you want to do this on them. You have to state that this is experimental and it will not, in no shape, way, or form, help or cure or treat anything. It is, if you're doing it properly, it is a homologous use product, meaning we can use it for viscosity and cushioning. That's what you're going to get. And then you have to leave it as simple as that. And I know it's incredibly difficult to try to convince a patient with vague words, but if at least the patients understand why clinics can't use that kind of wording, then at least maybe you have a better understanding of why you don't get to hear the words maybe you want to hear, is because those that are doing it correctly are kind of handcuffed on how they can communicate with you.
So far.
So
Yeah.
Yes, it is being done. You are seeing mesenchymal stem cells being done in the United States. You are seeing exosomes being done in the United States. You are not very rarely seeing manipulated cells being done in the United States. It's being done outside of the United States. And that is just because regulations really prohibit anyone in the United States doing that.
So that would be more like pain clinics you would find this in? Or
Yeah, anything from
clinics.
integrative pain clinics, orthopedic clinics, maybe even wellness or longevity. I don't know. There's probably, again, it's tough to Google and find this stuff because you can't put it out there. You know, FDA will quickly send you a letter if it's on your website. And so, you know, anything, if you claim anything, state anything, you're not allowed to right now. So really it's right now word of mouth, trying to find any clinics that are doing it, even some that are bold enough to put it on their website right now and kind of put their head above the clouds. There are clinics that do that, even maybe some that are blogging about it, but aren't stating anything. They're like, hey, what are stem cells on my blog? They're just telling you what stem cells are. They're not stating that they do it. They're not stating that it helps with anything. Maybe trying to find something like that, but
I'm sure it's a cash service, not going to be covered by
it's
insurance.
not covered by
any
insurance. It's
means
definitely
then.
cash.
Yeah.
Some places are way more expensive than others. In my opinion, the ones that are doing it the best are the ones that understand who they're getting it from. I definitely wanted to include this. There are many ways to get the donated placenta and screen for it properly and get the vials from the bank. Some just cut corners, some do proper processing. What sucks is it's really tough to understand and get all that from your provider who is trying to get that from the lab. There's still a lot that needs to be done in order to have a good confidence of what you're putting in your body. So to say that you can go and get this in the United States and receive what you think you're receiving it's tough. So how I would encourage you is having a proper conversation with your provider, asking him even just the things that we covered today. Do you know what a 361 versus the 351 product is? Do you know what an IND is? Do you know if your lab or whatever company you're getting from is doing the proper screening on the tissue? What does that look like? What are they screening for? And the companies that I've used give me all that. They talk about if they had an IND. They talk about why they choose to be a 361 versus a 351. They talk about the research done on their products. They give you the white papers. They give you all of these, cytochrome, all of the protein profiles, the cytokine profiles, what is in their vials. They give you all of that. They are upfront. They know how it's done. They even have friends that are in the FDA who help them.
Wow.
I mean, it's becoming that point now where you gotta be on the ball. If the FDA comes knocking on your door, you gotta know what they're gonna ask you. And it's not that the FDA hates these labs and doesn't want you to do these. They just want it to be safe.
Yes.
And so just because it's not approved doesn't mean it's not regulated. The FDA is regulating these labs. They're sending letters if it's not in compliance. You still need to have good manufacturing practice, GMP it's called, to have a proper lab. And so it's all being done. It's just even Googling and asking, let's say your provider tells you they're using this company, Google the company and see if they've gotten letters from the FDA.
Okay.
Again, it's going to take a little bit of legwork, but if you truly want this product, it is going to take that kind of work because you want to know what's going to be put in your body.
Man,
So,
which makes sense too. Goodness gracious. Yeah, that is incredible, Doc. Now, I just personally want to say thank you for all the info that you've delivered. You know way more about half this stuff from what I can hear than most practitioners that are even delivering these services on PRP, stem cells, exosomes. So I just want to thank you for all that.
Of course.
And even for the understanding, because the more people, practitioners that can understand the in-depth knowledge, not only from a broad overview, but also in terms of the depths of reasons why, I think gives us as a community and as a nation only more understanding moving forward. So,
and if any of you are interested, I don't want to put this on the podcast as far as my recommendations, and I don't want to do that. But if you want to message us privately, I would love to have a conversation with you guys on who I choose as my companies, what I would recommend you ask your providers, how to go about finding the best practitioners. Even if you're not in the state, I do know a lot of providers in other states that are doing this. So please let us know because it can be found and done in the United States. And I may have touched a little more heavily on what to do as far as what to avoid. But I really don't want you to feel like this is something you shouldn't do. In fact, I've done it on myself many, many times. I love it. I love exosomes. I love PRP. I've loved stem cells. It is very, very effective and for so many things. And so I've shoved them in all of it in my veins. I've done PRP in my veins, exosomes. I put it everywhere. Never had any adverse effects. It's only been positive. So no, I truly do recommend it if you are interested in doing it, just as long as you have questions, because I have no issue in helping you answer those questions.
That's beautiful. And like I said, if there is any other questions that you may have, please put them down below. We'll answer those in a timely manner. Leave any comments. Share this to any people that are possibly thinking about PRP, stem cells, exosomes, or any regenerative therapies, to any friends, family. When this comes out, this could be earlier on in the stages, opposed to when you may hear it or view this podcast. So by all means, share, ask. We're here to only help. So,
yes,
Doc.
Yes.
That is episode 14 on regenerative medicine.
Another day. See you guys later. Woo!
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the Functional Code. Until next time, stay well, stay informed, and embrace the science of living well.